Osimertinib in untreated EGFR mutated advanced non-small cell lung cancer. Definitions. Osimertinib is an oral third-generation irreversible epidermal growth factor receptor tyrosine kinase inhibitor EGFR TKI that selectively inhibits both EGFR TKI sensitizing and EGFR T790M resistance mutations. We compare osimertinib with the standard EGFR TKIs in patients with previously untreated EGFR mutation-positive advanced non-small cell lung cancer (NSCLC).
Epidermal growth factor receptor, or EGFR, is a transmembrane receptor tyrosine kinase that regulates cellular proliferation and apoptosis. Mutations in EGFR have been discovered in association with non-small cell lung cancer. First-line treatment of advanced non-small cell lung cancer with EGFR mutations with first- or second-generation reversible EGFR tyrosine kinase inhibitors, or TKIs, extends progression-free survival as compared with chemotherapy. Osimertinib is a third-generation irreversible EGFR TKI selective for both EGFR TKI sensitizing and EGFR T790M resistance mutations, but not wild-type EGFR. It can penetrate the blood-brain barrier to target metastatic tumors in the central nervous system. In this double-blind Phase 3 trial, 556 patients with previously untreated EGFR mutation-positive, locally advanced or metastatic non-small cell lung cancer were randomly assigned to receive either 80 mg of osimertinib once daily or standard EGFR TKI, 250 mg of gefitinib or 150 mg of erlotinib daily. The primary endpoint was investigator-assessed progression-free survival according to the response evaluation criteria in solid tumors guidelines. The median progression-free survival was 18.9 months in patients receiving osimertinib, as compared with 10.2 months in patients receiving standard EGFR TKI. Similarly, longer progression-free survival was observed in patients with central nervous system metastases who were receiving osimertinib. Adverse events of grade 3 or higher were reported in 34% of the osimertinib group and 45% of the standard EGFR TKI group. The authors conclude that osimertinib decreased the risk of disease progression as compared with standard EGFR TKI in first-line treatment of EGFR mutation-positive advanced non-small cell lung cancer, with lower rates of serious adverse events. Full trial results are available at nejm.org.
Applications in medicine. We randomly assigned 556 patients with previously untreated EGFR mutations-positive exon 19 deletions or L858R advanced NSCLC in a 1:1 ratio to receive either osimertinib at a dose of 80 mg once daily, or a standard EGFR TKI gefitinib at a dose of 250 mg once daily, or erlotinib at a dose of 150 mg once daily. The primary endpoint was investigator-assessed progression-free survival.
Upon activation, the EGFR ligand receptor complex has been shown in vitro to undergo internalization. The internalized complex is either sorted to lysosomes for degradation or recycled to the plasma membrane, where it may retain signal transduction activity. EGFR is the only member of the EGFR family that undergoes ligand-induced internalization. Despite the clinical benefit seen with first-generation EGFR tyrosine kinase inhibitors, insensitivity and/or resistance have been observed in non-small cell lung cancer. One possible mechanism for this is the presence of a point mutation in the ATP binding pocket, referred to as the T790 mutation. This mutation, which may be either innate or acquired, renders these tumors unresponsive to first-generation EGFR tyrosine kinase inhibitors. Therefore, new therapies are needed.
Pros and cons. Pros can be used alone without chemotherapy as the first treatment for advanced non-small cell lung cancer that has routine mutations in the EGFR gene. These are more common in women and in people who do not have smoke. It can be used for lung cancer that is not advanced microcytic and does not have those mutations. This medicine is taken in the form of pills. Cons. Common side effects of all EGFR inhibitors include skin problems, diarrhea, mouth ulcers, loss of appetite. Skin problems can include an acne like rash on the face and chest, which can sometimes cause skin infections.
For patients with advanced non-small cell lung cancer and a mutation in the epidermal growth factor receptor, or EGFR, first-line treatment is with an EGFR tyrosine kinase inhibitor, an EGFR TKI. Some patients initially have a good response to this treatment, but over time the cancer progresses in most. In up to 60% of patients who have a recurrence of lung cancer, a point mutation in the gene coding region T790M has been identified. The presence of this mutation is associated with reduced binding of the EGFR TKI therapy to the receptor, leading to less inhibition and to cancer progression. Osimertinib is an oral irreversible EGFR TKI that is selective for both EGFR and T790M resistance variants, with activity against metastases to the central nervous system. The international open-label AURA-3 trial included 419 patients with T790M positive advanced non-small cell lung cancer who had progression of cancer after prior treatment with EGFR TKI therapy. 144 of the patients, or 34%, had asymptomatic CNS metastases. Patients were randomized to receive a daily dose of osimertinib or intravenous platinum pemetrexed chemotherapy every 3 weeks for 6 cycles, followed by maintenance pemetrexed. The primary endpoint was investigator-assessed median progression-free survival, which was 10.1 months in the osimertinib group, as compared with 4.4 months among those treated with IV chemotherapy. The hazard ratio, 0.30, was statistically significant. A subgroup analysis of the patients with CNS metastases showed a median progression-free survival of 8.5 months in the osimertinib group, as compared with 4.2 months in the IV chemotherapy group. Patients in the osimertinib group had diarrhea, rash, and dry skin. Cases of severe myelotoxicity were less common with osimertinib than with IV chemotherapy. The authors conclude that in patients with T790M positive advanced non-small cell lung cancer and prior EGFR TKI therapy, treatment with osimertinib resulted in significantly longer progression-free survival than did IV platinum pemetrexed chemotherapy. Full trial results are available at nejm.org.
Frontline osimertinib, I think, is here to stay, at least for now. A 19-month progression-free survival is pretty impressive for a very well-tolerated drug. So for me right now, it's tough to imagine in the frontline combinations really coming in and beating that, both in terms of tolerability and in terms of outcome. I think the combinations will really come in the treatment of resistance to osimertinib. We're going to see more and more patients who are progressing on these drugs. Right now, we don't have any standard options for people who progress on osimertinib, except for cytotoxic chemotherapy, which I think many of our patients would like to avoid if possible. I think that's to be determined. So right now, normally, if people get erlotinib, afatinib, or gefitinib in the front line, then get osimertinib at resistance, I really don't go back to the TKIs when they progress. I tend to go straight towards chemotherapy. With osimertinib, we're learning more about the resistance mechanisms now, and there is some data that patients that progress with a C797S resistance mutation may actually maintain responsiveness to first or second generation agents, at least preclinically. I think clinically we don't have the data we need yet. So that'll be something to look for in the future. And then again, I think the combination trials are going to be very important in this setting. Like the TATN trial with the MET inhibitor in combination with osimertinib is very promising.
Each apply in Ecuador. As researchers learn more about the genes that help the growth of non-small cell lung cancer cells, they develop new drugs to specifically combat these changes. These targeted therapy drugs work differently than those commonly used in chemotherapy. Sometimes these medications work when chemotherapy drugs are not effective and often have different side effects. Currently, they are used more frequently for advanced lung cancers, either together with chemotherapy or by themselves in our country.
When a patient's newly diagnosed with adenocarcinoma of the lung, we have multiple different treatment choices now. We want to be thinking about whether or not they have a driver mutation, and if they have a driver mutation, particularly EGFR, ALK, ROS, or BRAF, we know that starting on a targeted agent, especially for EGFR and ALK, is absolutely the best approach for multiple trials. And so we would start them on an EGFR TKI if they have an EGFR mutation. We have choices of erlotinib, gefitinib, afatinib, or now osimertinib. There are trials looking at whether or not we could add other agents to those, like VEGF inhibitors, and we'll wait and see what those results show. If someone has an ALK translocation, then we can start with one of the ALK tyrosine kinase inhibitors, of which there are multiple approved: alectinib, ceritinib, crizotinib. First line in the US, there's a lot of use now of alectinib, and that would be an excellent choice for patients. Those others are also quite good as well. With ROS1, a little bit more controversy, but often would start with crizotinib or ceritinib. There's some data there as well. With BRAF, there's first-line approval for dabrafenib and trametinib combinations, so we'll often use that later. We'll then also be thinking about PD-L1 expression, and if someone has high PD-L1 expression, there's data to support using first-line pembrolizumab instead of chemotherapy. But there's also data now to support using chemotherapy plus pembrolizumab. And that benefit is seen across PD-L1 levels, but was more so in the highest levels. So that would be the option as well. So those are all the things that we would be thinking about and the data behind it. With the chemotherapy plus pembrolizumab, there was a clear overall survival benefit seen, as there was with pembrolizumab versus chemotherapy. With the tyrosine kinase inhibitors, it's a little bit trickier because there's not always overall survival because of such high crossover rates and such high response rates. So in trying to figure out which one to use, we have to think about the whole picture and all those various parts of information. With squamous cell carcinoma, it's a little bit less complicated. It's rare to find a driver mutation, though it can happen. So we don't look quite as much for those. With the checkpoint inhibitors, we don't yet have clear data other than if they're high PD-L1, we can think about using checkpoint inhibitors. There'll be more data looking at the combinations that should be coming out in 2018 that might be practice changing, but we don't know yet. So at this time, we're still focusing more on chemotherapy in the squamous patients.
Conclusion. Osimertinib showed efficacy superior to that of a standard EGFR TKIs in the first-line treatment of EGFR mutations positive advanced NSCLC with a similar safety profile and lower rates of serious adverse events. Thank you.